A very good morning to all of you. We'll be starting this session, and I'll just see whether all the speakers are here. Shivan Maria, yeah, Nikunj Maru, Nikunj, Imran Sajid, Atul, Rohit Vajpayee, Pratik Shah, Umang Agrawal, Paritosh Gogna. Right, so we have 3 speakers at present. Maybe they'll join us later. So without wasting much time, since it's getting on to 9 o'clock, I just request the speakers to keep to time, and we'll be allowing you just 6 minutes with 1 minute for discussion, because you have just 7 minutes per this thing. So I request you to keep to time, because we'll be marking the time. So we have the first speaker, Dr. Shivan Maria, and he'll be speaking on use of 1/3 tubular plate for fixation of subtrochanteric fractures of the femur in children, an innovative technique. Shivan.
Good morning, Chairperson, respected teachers and friends. Today I shall be describing to you an innovative technique that we have devised at the Sancheti Institute for the fixation of subtrochanteric fractures of femur in children between the age group of 3 to 6 years. In literature, these injuries have been defined as those involving the proximal 10% of the femur below the level of the lesser trochanter. They are rare injuries but difficult to manage even in the most experienced of hands. One may ask, why not conserve these fractures? The answer is that these fractures have deforming forces acting in 3 planes. Hence, a close reduction and not fixing the fracture could lead to loss of reduction, which would cause mal or non-union at the fracture site. Also, for early mobilization of these children, it is recommended that we fix the fractures. The next question that arises is, why not fix them the same way we do in adults? Now here I would like to tell you that this is not a mini-me situation. Because of the presence of the trochanteric and capital femoral epiphysis, a standard antegrade femoral nail or a sliding hip screw device cannot be used, as it would damage the growth plates. Now, what is important in the use of this technique is proper patient selection. Children between 3 to 6 years should only be selected for the use of this technique, and it should be used only for fractures involving the proximal 10% of the femur. Also, all children above 30 kgs of weight should not be subjected to this technique, and we did not use it for pathological fractures either. On searching the literature, various implants have been described for the management of these fractures, including the titanium elastic nailing system and plates such as the phylos and the distal tibial plate. So why not use TENS? The latest article in the Bone and Joint Journal in January 2013 states that TENS works on a principle of 3-point fixation and spindle effect, which is indicated primarily for diaphyseal fractures. Therefore, they also say that a plate or surface fixation is preferred over TENS in fractures involving the proximal part. Other plates, such as the phylos and the distal tibial plate, have been actually described for the treatment of these fractures in older children, somewhere in the age group of 8 to 12 years. However, the children that we are describing the technique is only 3 to 6 years. So why the 1/3 tubular plate? The answer lies in the fact that this is a thin and malleable implant. It is easy to contour, yet it provides sufficient stability, and more importantly in our context, it is cheap and very easily available. Our surgical technique involved placing the child in the supine position and taking the standard lateral approach. After identifying the fracture fragments, as you can see on this slide, we used a 2.7 millimeter drill bit to create holes in the lateral cortex of the proximal femur 1 centimeter below the level of the greater trochanter. After creating these holes, a slot was created using a 5 millimeter osteotome under C-arm guidance and directed upwards towards the capital femoral epiphysis, but lying just short of it. After creating the slot, a standard 1/3 tubular plate was inserted into the slot as is shown in the diagram. Then using a screwdriver and placing it in the proximal most screw outside the femur, we bent the plate and contoured it along the lateral surface of the femur. After this, using bone clamps, the fracture was reduced to get a final position of the plate as shown here. And then fixation was done using standard 3.5 millimeter cortical screws and one oblique screw in the proximal most hole to prevent back out of the plate. Post-operatively, a cylinder cast immobilization was given to all children for 3 weeks to prevent weight bearing, and after 3 weeks, the cast was removed and child was mobilized as pain permitted. Our experience so far with this technique has been with 9 children, 5 girls and 4 boys, between 2003 and present. Here you can see a subtrochanteric fracture of the left femur in a 4-year-old girl, the preoperative x-rays. Intraoperatively, the C-arm images of the technique that we have employed. Immediately post-operatively, you can see the cast that has been applied here. At 3 weeks follow-up, we can see good callus formation at the fracture site. And at 3 months, there is full radiological union and clinical function is returned. Yet another case of a 4-year-old boy who was treated using the same technique, and once again, after 3 months, he had full range of motion in the hip joint. And the post-op x-rays of another case that we had done. The results that we have seen in these patients are that all patients showed good clinical and radiological union by approximately 3 months post-operatively. All children were evaluated using the Ratliff criteria and a good outcome was seen. No complications were encountered that warranted resurgery. In conclusion, the technique we described here is safe, cheap and easily reproducible technique to treat these difficult fractures in children between the age group of 3 to 6 years. Thank you.
Well, thank you, Shivan, for keeping to time. And now the paper is open for discussion. Any questions from the house?
Why did you apply plaster cylinder cast in these patients?
Sorry, sir, could you repeat yourself?
Why did you use cylinder cast?
Yes.
To protect it.
So
it does not help.
Yes. So the purpose of using the cylinder cast was two. One was to prevent the child from mobilization, and we preferred that to a hip spica or a Thomas splint, as those would be more cumbersome. The second is the cylinder cast prevents flexion at the knee joint and rotation movements at the fracture site, which we had just fixed. So this was applied for 3 weeks duration.
Did you get any case of avascular necrosis of the neck in your series?
So in the cases that we've followed up so far, we haven't encountered any cases of avascular necrosis.
But in the short duration, it is not expected to get?
Yes, so that is also maybe the limitation so far, that our follow-up, but we do have one patient from 2003 as well, and he hasn't shown any signs of AVN yet.
So in this age group, that is 3 to 6 years, I think most of the fracture, I mean 100% fracture will unite conservatively. What is the need to fix such fractures?
As I had described in one of the previous slides that I had shown, there are both rotational, angulational and shortening deformities in these fractures. If we do, or if we are ready to accept malunion at the fracture site and possible, because of these deforming forces, then conservative methods can be tried. However, literature review does strongly support, and evidence does support, fixation of these fractures over non-operative management.
Whichever malunion is there, it is expected to correct itself.
Excuse me, doctor. Let other people also ask questions.
Thank you.
Time is short.
Is there likelihood of implant failure in these cases? That is one.
Yes, sir. So that is why I had also described that which patients to operate and which not to operate. Another intraoperative guide that we had taken is when we applied the 1/3 tubular plate to the lateral surface of the femur, if the plate was approximately 2/3 the width of the femur or more, then we continued with the procedure. However, if not, then we would not recommend the use of this plate.
Well, thank you, Shivan. I think, sir, I request the audience,
Just one
because
question.
just 1 minute is there for a question and answer, and we are short of time actually, sir.
Thank you, sir.
In one case, there was coxa valga, or abduction at the site of fracture.
Sorry,
Do you
sir.
expect that this will mold in due course of time?
Yes, sir. In due course of time, we would expect that to mold.
Well, I congratulate you for a good paper.
Thank you, sir.
We go on to the next one, and that is by Nikunj Maru. Is he here? Well, then we go on to the third paper, and that is by Imran Sajid. And he'll be speaking on distal humeral fractures, internal fixation with a principle-based technique, depending on fracture configuration.
Good morning, Chairman and the fellow delegates. For the next few minutes, I'll be talking about the distal humerus fractures, internal fixation on a principle-based technique. Before starting, let's revise the distal humerus anatomy a little bit. Distal humerus, as we all know, is formed by the lateral and the medial column, and which is joined by the tie arch, that is the articulating surface. However, there is a few angulations also associated with it. The medial flange of the trochlea, because of its prolongation 6 mm, there is a valgus alignment 4 to 8 degrees and anterior angulation 35 to 40 degrees, which gives the distal humerus a hockey stick appearance. The distal humerus fractures are not new. They have been happening long before. They are happening today and will keep on happening. However, the fixation method has changed. Till 1970, the conservative treatment was thought so. The patients were not operated and given in an arm pouch. After 1970, with the development of the IOACON group, the principles of the treatment have changed. Thus, surgical reconstruction is now thought upon unless the patient is medically unfit. The implant choices, LC-DCP, the recon plates, the tubular plates, distal humerus plates have come into. With the advent of the new AO distal humerus plates, the pre-contoured plates, which are more advantageous in the osteoporotic fractures. The implant biomechanics. The main principle of the fixation of the distal humerus fractures lies in the reconstruction of the articular surface. Routinely, the medial and the lateral columns are reconstructed using the orthogonal plate technique or the 90-90 principle, or the medial and lateral parallel plates, or the posterior plate. A third plate is also added sometimes. Perpendicular plating versus parallel plating. When the IOACON group was formed, it came with the principle of orthogonal plating, that is a 90-90 technique. Whereas, furthermore, the people started doing orthogonal plating and they found some issues. So the parallel plating configuration was developed, but there has been conflicts of interest with both the plates. Which is superior has still a debate going on. Parallel plating concept. It's a tie arch mechanism where the distal humerus articular surface is fixed with screws to give the intrinsic stability. It can be compared to the building of construction of a building where the concrete is underlined by the steels to give the intrinsic stability to the building. The perpendicular plating, the orthogonal plating is the 90-90 mechanism where a middle plate is used and a posterolateral plate is used. Now let's see a few cases. This is a patient with a distal humerus fracture. It was fixed with the orthogonal plating. This is a follow-up. The patient he has a good range of movement. This is another patient. He also had a distal humerus fractures. He was fixed with the orthogonal plating, but with the 2 months follow-up, following the patient was on mobilization, the patient had a screw back out and failure of the fixation. This is another fracture. He had similarly distal humerus fracture. He was fixed with the parallel plate technique. Another fraction, this patient has got a lot of comminution in the distal articular surface. Parallel plating technique was used. The distal humerus fractures are basically the very complex fractures. Why the distal humerus fractures are complex? The association of the bone quality, whether the osteopenia is associated, the bone loss associated with the trauma, the greater the comminution, how the fracture is extending. All these factors associated make the distal humerus fractures complex fractures. This is a distal humerus fracture, greatly comminuted, extending intra-articularly. Distal humerus fractures. While fixing the distal humerus fractures, a few technical objectives were given by the old Riscals of the Mayo Clinic. What he said was, every screw should pass through a plate. For each screw should engage a fragment on the opposite side that is also fixed to a plate. As many screws as possible should be placed in the distal fragment. Each screw should be as long as possible. Each screw should engage as many articular fragments as possible. The screws should lock together by interdigitation within the distal fragment. Plate should be applied such that compression is achieved at the supracondylar level for both columns. Plates used must be strong enough and stiff enough to resist breaking or bending before union occurs at the supracondylar level. Because most of the cases, the plate gives away at the supracondylar level when we start mobilizing. These are the technical objectives shown in the diagram. The screws must be long enough. Each screw should pass through a plate. Each screw should be holding a distal fragment, and they should be compressing at the supracondylar level. What is essential in distal humerus fracture is identifying the fracture geometry. You should understand the patient, what is the bone condition, how
Dr. Sajid, just summarize.
combination is. What I want to say
Just
is,
summarize that this thing is over. Your time is over.
take-home message is each distal humerus fracture is unique. Remember the principles, no preformed notion, plate configuration not decided by the surgeon but by the fracture. Thank you.
Well, thank you, Sajid. The paper is open for discussion. Any questions? I know the principles of this are very well understood by people. Anything new you would want to suggest, because you said principle based?
Yes,
what do you
sir.
mean by this? Because all these principles are well laid out, all of us follow these principles.
The main aim of this talk was, there is orthogonal plating and the principles based technique. What I want to say is the simple thing, we should not go by the preformed notion. We should understand the fracture configuration, what does the fracture wants, and we should understand reconstruction of the articular surface is the most important. We should not fix on whether we are going to do 90-90 plating or the parallel plating. We should see the fracture geometry, and then decide intraoperatively what the fracture wants.
Right, okay. Thank you, Sajid. I will go over to the next talk, and that is by Dr. Atul Tat. And he'll be speaking on comparative study of 3 different posterior approaches for intercondylar fractures of the humerus.
A very good morning to all. I am Atul Tat, second year resident from Arjikar Medical College, Kolkata. My topic is comparative study of 3 different posterior approaches for intercondylar fracture humerus. Introduction: the fracture of distal humerus often lead to destruction of intra-articular anatomy, which has significant effect on the motion and functions of elbow joint. Open reduction and internal fixation of the distal humerus fracture is the gold standard treatment, but the controversies exist regarding surgical approaches, type of implants, operative techniques, need for transposition of ulnar nerve, place of primary total elbow replacement, type of rehabilitation after surgical treatment. The posterior approach provides proper exposure to the articular surface, so it is also called as front door to elbows from back. There are 7 different posterior approaches. This study, the aim of the study is to establish superiority of those, any one of the 3 surgical posterior approaches. The one is olecranon osteotomy, also known as Muller and McCausland, triceps reflecting and triceps aponeurosis tongue. Materials and methods: the study area is the Department of Orthopedic Surgery, Arjikar Medical College, Kolkata. Study population is the patient attending outdoor and emergency. The sample design is a purposive sampling. It is a prospective interventional study. This study comprises of total number of 30 cases. First case was operated by olecranon Brian Moore approach, second by olecranon osteotomy, and third by Campbell's approach. This sequence was maintained throughout the study, and hence the 10 cases were operated by each method. The distribution of C1, C2 and C3 type of fracture is the intra-articular fracture AO classification. There are 40 patients of C1, 11 of C2 and 5 of C3. C3 is the most complex fracture. Materials and method: patients with open injury were excluded from the study. Similar implants are used in all cases of fracture. Ulnar nerve transposition was not done in any of the cases. You can see the intraoperative photograph of olecranon osteotomy when there is good exposure of fracture site. This is a Brian Moore's approach, triceps is being reflected. This is a Campbell's approach, triceps aponeurosis tongue is being made. On follow-up, patients were reviewed every 3 weeks for the first 2 months, every one for 6 months, and every 3rd month for 1 year. And they were assessed on time taken for the functional recovery, range of motion, time taken for fracture healing. And the scores were evaluated after 1 year of follow-up. The grading of result is done by Mayo's elbow performance index score. This score has 4 points: pain, motion, stability and function. Pain is awarded 45 points, motion 20 points, stability 10 points, function 25 points. Total score is 100, excellent score is more than 90, good is between 75 to 89, fair is between 60 to 74. Poor result is score less than 60. This is the Mayo's MAP score in our group of patients. It is 84.5 in Brian Moore's approach, 94.5 in olecranon osteotomy and 87.5 in Campbell's approach. So you can see it is excellent in olecranon osteotomy. The range of movement is assessed by Riseborough and Radin method, Casaubon method and Mayo's elbow performance index scoring system. In Casaubon method there are 4 grades. Excellent is flexion between 15 to 120 degree, good is between 30 to 120 degree, fair is between 40 to 90 degree to 120 degree. Poor flexion is between more than 40 degree to less than 90 degree. In Riseborough Radin method there are 3 groups. Good range of motion is a flexion contracture of 30 degree or less to at least 150 degrees of flexion with or without minor subjective symptoms. Fair range of motion is between 30 to 60 degree of flexion contracture to at least 150 degree, and poor range of motion is a flexion contracture of more than 60 degree to less than 150 degree. There is a flexion extension arc. In Brian Moore's approach it was 91.5 degree, in olecranon osteotomy it was 117 degree, in Campbell it is 96.5 degree. This is actually MEPI score in Brian Moore's approach. 40% cases has excellent result. In olecranon osteotomy, 90% cases had excellent result. In Campbell's, 30% has excellent. Good result is seen in 50% of Brian Moore's and 60% of Campbell's approach. Fair result is seen in 10% of each. His time required for functional recovery is 90 days for Brian Moore's approach, 65 days for olecranon osteotomy, and 108 days for Campbell's approach. Now, this study also has some complication. Most common complication of superficial infection, which was treated by antibiotics. The 2 patients had symptomatic hardware, but implant removal was not required. 1 patient had symptomatic tension band wiring, but implant removal was not required. And there were 2 cases of post-operative ulnar neuropraxia, which did not recover post-operatively. And there is 1 case of non-union of fracture site. It was not the non-union of olecranon osteotomy. It was the non-union of fracture site of olecranon osteotomy. Time required for fracture healing, it was 85 days in Brian Moore's, 78 days in olecranon osteotomy, and 90 days in Campbell's approach. You can see the clinical photograph. This case was operated by olecranon osteotomy. There was no range of restriction of movement. This was operated by Campbell. There is restriction of movement. This was Brian Moore. There is some restriction of movement. So in discussion, this study population is comparable with respect to gender, side, and age. Most number of complex fractures were operated by olecranon osteotomy. There were 7 fractures operated by olecranon osteotomy, and most simple type of C1 type of fracture was operated by Campbell's approach. In view of functional recovery, we found significant difference between olecranon osteotomy and Campbell's approach, but we failed to find any significant difference between olecranon osteotomy and Brian Moore's approach. Visibility of fracture site in olecranon osteotomy approach was far better than Brian Moore's approach, was better than Campbell's approach. When we statistically analyzed the mean flexion extension arc, there was no statistical difference. The approach used for fixation of fracture had no relation with fracture healing. At final follow-up, all patients were assessed by MEPI scoring system. We found results in patients operated by olecranon osteotomy much better than, whereas only, in Brian Moore's approach 40% cases and Campbell's 30% cases had excellent result. But when we statistically analyze the data, the mean results of 3 groups are statistically insignificant. So it can be concluded that among the 3 approaches being studied, intercondylar fracture humerus, olecranon osteotomy approach provides adequate exposure to distal humerus, which facilitates the accurate articular reduction even in complex type of fractures, and early mobilization can be instituted, which is the crux of final outcome. Thank you.
Well, thank you, Atul. Just one question can be asked because of shortage of time.
King? Yeah. Does the approach affect the results or the fracture anatomy affects the result?
Fracture anatomy, sir.
So, is the fracture type the same for all?
No, sir. There were 30 cases of fracture, 30 cases out
So
of
is
which...
it worthwhile comparing?
No, sir. It was... Okay, sir. Thank you.
Yes, okay.
The infection rate in your superficial infection,
Yes.
you had 4 patients in 30 patients.
Yes.
That is almost 13%. Almost 13%
Yes,
infection rate.
Yes.
Isn't
Yes.
it's high? I mean, why it was so high?
Sir, in government hospital, we know the kind of facilities we have.
Thank you, Atul.
Thank you, sir.
And we'll go over to the next paper, and that is by Dr. Rohit Bajpayee, and he'll be speaking on internal fixation fractures of lateral humeral condyle.
Good morning, everybody. Respected chairperson, sir, and all the delegates. I'll be speaking upon a paper on internal fixation in fractures of lateral humeral condyle. It is a frequently misdiagnosed fracture of distal humerus, usually diagnosed when patient presents with one of the complications. It is very common in children, and the spectrum of complications ranges from malunion, non-union, cubitus valgus to tardial nerve palsy and fascial injuries of the lateral condyle. And the management controversy exists. Aims and objectives of the study: to compare the results of open reduction and internal fixation in fresh and old fractures of lateral humeral condyle, to evaluate and compare results and behavior of the fractures of lateral humeral condyle fixed internally in children and adults, and to study late results of operative management. Methods and materials: total 38 cases were operated with open reduction and internal fixation and followed up for 2 months to 12 years. the youngest being of 4 years, the oldest being of 45 years, with an average age of 7 years. Mechanism of injury, it is an indirect violence which results from fall on outstretched hand. Two theories have been put forward. First is avulsion theory, that is pull-off theory, and second is push-off theory. In pull-off theory, the elbow is in extended, abducted with forearm supinated and forceful varus at elbow. Fracture extends from to the trochlear notch. And in the second theory, push-off theory, there is fall on palm with elbow flexed. Radial head is forced against the capitulum, causing the fracture through capital trochlear notch. The classifications put forward are the Mills classification, which explains the anatomy of the fracture, that is type 1 and type 2. Type 1 is relatively uncommon, but type 2 is common. In type 1, fracture line extends lateral to trochlea through capillotrochleal groove, and type 2, fracture line extends into the apex of trochlea. The Wandsworth system, which stages the displacement of the fracture fragments. Type 1 is metaphyseal fracture is a rim of bone which is not displaced, and type 2 is subluxation of the metaphysis and the epiphysis. Type 3 takes accounts into the rotary displacements of the fracture fragment, and type 4 is due to compression of radial head impingement into the capitulum. Objectives of the operative management were establishment of the condylar alignment to try and align the axis of rotation of the condyles, restoring developing osseous link between the trochlea and the capitular surface to maintain congruous joint surface and adequate lip of trochlea, and achieve anatomical reduction of fracture line with stability to achieve early complete range of motion. Standard Korcher's approach was taken. Methods of fixation was open reduction internal fixation with cross K wires or parallel K wires, preferred being that of cross K wires. This is cannulated cancellous screw fixation in case of adults. These are the pre-operative and immediate post-operative and 3 weeks follow-up radiographs of the patient. These are the photographs depicting functional outcomes. The study was based on Hardacre criteria, which takes accounts of status of union, range of movements, status of epiphysis, and change in carry angle and other signs. This is the Hardacre criteria. Results were evaluated on the functional and cosmetic basis suggested by Hardacre. In fresh cases, 5 cases, that is approximately 13%, where came out to be the excellent results. Good 37%, fair 10%, and poor in 8% cases. In late cases, almost 37% where we got good results, and 10% fair and 8% poor results. Comparative study of children and adults, 16% of the children we got excellent results, and in adults approximately 25%, with total of 90% of children being studied and only 10% of the adults studied. The complications here are the prominence, cubitus valgus, premature epiphyseal closure, avascular necrosis, delayed union, malunion, and arthritis. The most common being prominence and cubitus valgus. Conclusions. All displaced fractures should be treated by open reduction and internal fixation. Early surgery does not ensure good results unless reduction is near anatomical. Minimum soft tissue dissection should be done to prevent avascular necrosis, and passage of K wires through the center of epiphysis doesn't cause much growth disturbance. The takeaway message is, it is a fracture of necessity, therefore must be fixed. All the displaced fractures should be fixed promptly with open reduction and internal fixations. Minimum of 2 pins are required to prevent the rotation of the fragment, and definitive open reduction and internal fixation of fractures up to 6 weeks should be done. Thank you.
Thank you, Rohit. The paper is open for discussion. It's a good presentation, and there will be questions. Sir.
I am Dr. Vaishnav from Agra. You see, the deforming forces on this fragment are 2-dimensional.
Pardon, sir?
The deforming forces on the fractured fragment is 2-dimensional, not 1. So how can your 2 K wires can overcome these 2 deforming forces?
Sir, it is K-wire should be placement of K-wires is decided upon like 2 K-wires and 3 K-wires depending upon rotational stability.
No, could you understand two-dimensional deforming forces?
Hello? Pardon, sir?
Could you understand the two-dimensional deforming forces? You can automatically go for 3.
No, sir. Please explain, sir.
Yeah. And all should be fixed, whether they are displaced or they are not displaced. Any fracture in lateral condyle must be fixed.
Yes, sir.
Okay. Dr. Mittal, please.
You have mentioned in
We'll
complication
go to the next question, please.
cubitus
Rohit?
valgus, but you have not mentioned delayed or tardive ulnar palsy, which also frequently occurs if this cubitus valgus persists for many years. You have not mentioned about that. It's quite common.
Yes, sir.
And I have seen a case of bilateral fracture lateral condyle with delayed ulnar palsy. He was a milk vendor and an adult. First he got had cubitus valgus, and then you see the delayed ulnar palsy after 5 years of this fracture. So he was advised this ulnar transposition. I advised for the other side also so that he doesn't, you see, get it. But when he got the other side, then he got operated for the other side also. And they recover if you do ulnar transposition.
Yes, sir.
All right. Thank you, Rohit. No more questions on this. No more questions on this. We have short of time, please. Sorry for that. I will go over to the next, and that is Pratik Shah, and he will be speaking on treatment of knee type 2 fracture distal and clavicle, a systemic review of treatment modalities in 35 fractures. Pratik.
Good morning, everybody. Today my topic of discussion about the treatment of knees type 2 distal and clavicle fracture, a systemic review of different modality of treatments in 35 fractures. I declared I have no conflict of interest. This figure shows the anatomy of lateral and clavicle and its various attachment, ligamentous attachment. Here is a main concept about the corticoclavicular ligament. In past, it was believed that almost all the clavicular fractures were treated conservatively, but in 1968, the Carter R. Rowe says the fracture of clavicle treatment has been greatly underrated in respect of pain and disability. At that time, also he has found that these type 2 fractures were highly unstable in nature, and if treated, they are treated conservatively, frequently leads to non-union. So, what are the goals of this treatment, these fractures? The prevention of non-union, good functional outcome, no pain, and no cosmetic wear. This all, we can achieve all these goal of treatment of distal and clavicle with a operative modality. What is about current concept? The treatment of this recent published article of Journal of Shoulder and Elbow Surgery about the current concept regarding the treatment of lateral and clavicle suggestive of the displaced fracture with or without corticoclavicular ligament needs the surgical fixation, and if possible, plate fixation is preferable. But there are the several methods of fixation in literature has been suggested for this type of fracture treatment, but none of them has been considered the gold standard. So the debate regarding the distal and clavicle fracture to choose which modality of treatment is suitable is still continued, and hence our study was warranted. The purpose of our study to identify non-union and other complication rate according to the treatment modality, observe the functional outcome, determine the which modality of treatment is most suitable. We have included in our study the 35 knee type 2 fractures between in our institute, which between the March 2009 to 2011, among which 10 were treated with non-surgical in form of the figure of 4 and a figure of 8 bend with arm sling, and 20 were operated with surgically, among which 10 with fixed with lock plate fixation with or without corticoclavicular stabilization, 10 patients with tension band wiring, and 5 patients with hook plate fixation. This the surgical treatment was chosen upon surgeon's preference. These are the few inclusion and exclusion criteria depending on which we exclude and include our patient in our study. All the patient operated through the standard anterior-superior surgical approach. Patient was assessed by the desk SLR's constant shoulder score and radiographical evaluation during their follow-up. This slide suggestive of the highly reliability of the constant shoulder score scoring system. results and discussion. There were the 26 male and 9 female with an average age of 43.2 years. Average duration of follow-up was 16 months and average union time was 10.75 weeks. In our study, among the non-surgical treatment, the treatment modality, 30% non-union found compared to the 8% in surgically treated group. But in TBW, a patient operated with tension band wiring group and the hook plate fixation had a higher union rate and excellent function outcome. But these two modality of treatment associated with higher complication rate compared to the other treatment modality. But use of lock plate implant was found to be superior among the all different modality of treatment included in our study in terms of the union, functional outcome and complication. All the facts have been supported in our study by comparison of available literatures. And regarding about the cosmetic deformity, there are the 60% of patient who were treated with the non-surgical treatment had a cosmetic deformity, which is also support the treatment. This type of fracture require the surgical treatment. These are the few limitations of our study. So conclusion is the surgical treatment of this type of fracture is more appropriate than the non-surgical management in recent era to prevent the non-union, functional disability and cosmetic deformity. And if surgical treatment we consider the lock plating is being most preferable implant. These are the few cases of our study operated with the locking plates, different type of locking plates. This one patient is having the combined coracocular fixation showing the good excellent outcome. This one is a complication of the conservative treated patient. So the message was the distal and clavicle fractures should be treated individually after the sufficient discussion with the patient. Non-surgical treatment can be considered in old inactive old household person or if patient was not medically fit. And if surgical treatment is preferred, and if surgical treatment we choose, the lock plate is best implant among all the available modalities. Thank you for your kind attention.
Thank you, Pratik. Any questions from the house?
In one of the case, why did you fix right up to the coracoid? In one of the case, you had fixed a plate right up to the coracoid. One screw was passing right up to the coracoid. What was the reason?
In some cases, we first put up. There are two ways of treatment of the lateral clavicle: the horizontal fixation and vertical fixation. In some cases, after we fix the fracture with the plate, there is also the coracoclavicular ligament. Coracoclavicular interval is not much appropriate. At that time, we insert the coracoclavicular screw and that patient.
Why don't you reconstruct the ligament rather than fixing? What was the range of movements after the fixation?
Sir, coracoclavicular interval is more important in these type of the fractures.
What was the range of movements of the shoulder?
What is?
What was the range of movements of the shoulder after fixation, such a fixation?
No, we are not compare that type, that data.
No, in this patient,
we only use this constant shoulder.
Pratik, the question is in this patient, what was the subsequent range of movements of the shoulder?
Okay, full range of motion, sir.
Surprising.
Full range of motion.
Well, thank you, Pratik. We'll go over to the next paper, and that is by Dr. Umang Agrawal. Is he here?
Good morning, everybody, chairpersons and delegates. Today I am going to present my paper on outcomes of modalities of treatment of intra-articular fractures of distal humerus in adults. I have no conflict of interest. In the introduction, intercondylar fractures are very difficult injuries to treat. The difficulty in its treatment is due to its complex anatomy, the adjacent neurovascular structures, the sparse soft tissue envelope, comminution occurring at the fracture site, osteopenia in the elderly patients, and the displacement which combines these to make these fractures difficult to treat. The good range of motion at the elbow joint is very essential for our daily day-to-day activities, like for the personal hygiene, for eating, for dressing, and for combing hairs. Controversies exist in the management regarding the surgical approach, type of fracture stabilization, and need for the transposition of the ulnar nerve. So aim of my study is to analyze the results of operative management and the difficulties associated with it. Risenberg and Redden classification, which we are very well versed with for the distal humerus fractures. Goals of the treatments for this intra-articular fracture is anatomical restoration of articular surface, stable fixation, and early mobilization. I have done a prospective study of 40 cases of supracondylar intercondylar fractures of the distal humerus fractures. Maximum incidence was found in 4th and 5th decade. Male is to female ratio was 2.3:1. Closed cases were 90% in my study. Average duration of follow-up was 16 months. These are the inclusion and exclusion criteria for my study. A complete clinical examination was carried out in every patient. The patients were operated either by close reduction and fixation or by using the open method using the paratriceps or the transolecranon approach. This is a schematic representation for a paratriceps approach and its clinical picture, and a schematic representation of a transolecranon approach and its clinical picture. The fractures were fixed either by using the bipolar plating or by using the K-wire or the cancellous screws. I have done the evaluation of my results by Mayo's elbow performance score. In the observation results, the implants used for the internal fixation was bipolar plating was done in 85% of my patients and K-wiring was used in 15%. Approach used was close reduction and K-wiring in 15%, open reduction by paratriceps approach in 55% and open reduction by transolecranon approach in 30% of patients. The range of motion was excellent in 40% patients, good in 40% patient and poor in 20% of the patient. Post-operative mobilization was started at 1 week in 50% cases, at 3 weeks in 30% and greater than 6 weeks in 20% cases. The fixation modality used K-wire, the mobilization was done greater than 6 weeks. Complication occurred in my study was infection, implant failure, non-union of the distal humerus fracture and painful hardware. However, I have no any case with the ulnar nerve neuropathy or non-union of the olecranon osteotomy site. Objective evaluation, I have excellent and good results in 80% of my patients. These are the few cases which we have taken and given clinical and radiologically excellent results. So to discuss management of these fractures is always been an enigma for the orthopedic surgeons because achievement of articular congruity is not so easy. However, with the availability of the newer implants, the improved surgical techniques, the operative results have been improved. Early mobilization decreases the fibrosis and intra-articular adhesions. Thus, excellent and good result can be achieved even in RR type 3 and 4 injuries. However, we have still fair and poor results in RR type 3 and 4 injuries because of articular comminution, because of prolonged immobilization and poor fixation. And this is a table depicting the same. And this point has been supported by this article published by Jarko et al. In Journal of Shoulder and Elbow Surgeries, and they suggest that immobilization exceeding greater than 3 weeks are associated with reduced elbow motion. In my study, I have used paratriceps approach more commonly, which involves minimum damage to the triceps muscle, minimal soft tissue damage, and resulted in good outcomes. However, in patients with the severe comminution in the intra-articular region, we require the transolecranon approach. And the paper published in JBJS in 2012 by Jason et al. And they suggested that the use of the paratriceps approach is giving good outcomes in most of the patients. I have done bipolar plating in perpendicular fashion in 85% of my patients, which is supported by an article published by Hochschild et al. And they use the perpendicular plating system for stabilization of these articular fractures and have achieved the 81% good outcomes in their patients. We have not transposed ulnar nerve in any of our patients and supported by the article given by Chen et al. In Journal of Orthopedic Trauma and he says that ulnar nerve transposition is not at all required in distal humerus fractures. Fair and poor results were common when the injury to operation interval is greater than 72 hours because it leads to soft tissue stiffness and increase in the joint stiffness. These are the few limitations of my study. So to conclude, open reduction and bipolar plating are preferable than K-wiring as the adult humerus is different from the pediatric humerus. Stable internal fixation is best accomplished by bipolar plate fixation, and for optimal biomechanical stability, both plates should be placed at right angle to each other. We must stick to the basic principles of open reduction and internal fixation. The olecranon fossa should be clear of the implants. Ulnar nerve transposition is not necessary, and ulnar nerve paralysis can be well prevented by proper placement of implant and gentleness during surgeries. Post-operative physiotherapy is most vital, and new implants like pre-contoured anatomical plates are giving the excellent results. However, the further randomized control triads are required to agree on the same. So the take-home message of my study is adhere to the well-described principles during open reduction and internal fixation. Bipolar fixation in the orthogonal fashion provides stable fracture fixation. Ulnar nerve transposition is not necessary and mobilize the patient early. While deciding the type of the operation, we must welcome the future, remembering that soon it will be the past, and we must respect the past, remembering that once it was all that was humanly possible. Thank you all for your attention.
Thank you, Umang. Any questions? Well, thank you, Umang. We've already had discussion in the previous paper, so we pass on to the next paper, and that is by Paritosh. Is he here? Paritosh? Is Nikunj Maru here? So we have sufficient time, so I'll just add a few comments. One is that we've had these presentations from our young budding orthopedic surgeons, and I must congratulate all of them for first keeping to time. All their presentations were very confidently presented, and they all brought out clear take-home messages, and I'm sure they'll be doing much better in the future. My only advice to them is, rather than spending a lot of time on just mentioning what is already there in the literature, they should present more of their own work, speak more of the work they have done, rather than spending 50% of the time on discussing what the literature already says, because all that is already known. So we want to hear mainly what you have to add to the literature and what work you have done. So in future, I think they should be doing well, keeping all these things in mind. Well, thank you. Of course, you can add.
I want to ask the house, what do you do with the loose fragment, articular fragment, if it is there, after parallel plating?
Well, I think, you know, anybody from the house who wants to answer it, otherwise I'll answer that. I, for one, would always reconstruct the width of the trochlea, and that has to be done with bone grafting. So you have to, if there are loose fragments and you feel that the articular surface is deficient, then it has to be reconstructed. The most important thing is the width of the trochlea, because if you compress also too much and the width of the trochlea decreases, that would hamper the range of movements. So width of the trochlea is very important, and it has to be reconstructed even if you have to add a bone graft. And a stud graft from the iliac crest, a tricortical stud graft, is what I would use.
How do you fix the graft then?
If you are using a tricortical graft to keep the width of this thing, then you fix it with a 4 millimeter cannulated canceller screw or with a malleolar screw. That's what I use.
Do you use a headless screw at this time?
You don't need to. You don't have to go through this thing articular cartilage. You have to just transversely fix it. Transversely fix it extra articular.
Thank you.
But it has to be reconstructed. It's very important that the width of the trochlea has to be maintained.
Do you keep the 1 centimeter of small articular surface in between the trochlea and capitulum at that place without fixing it? Or do you remove it?
No, the whole trochlea has to be made, and you must also see that the whole dimensions of the olecranon fossa.
Sir, my question is, trochlea and capitulum are all right. In between intercondylar, there is 1 centimeter small piece of articular fragment with small bone. Do you keep it there?
Of course you have to.
Without fixing?
You have to keep it like that. No, you have to fix it with a K-wire. Every articular...
This is so small you cannot...
Every intra-articular fracture can get displaced from there. So just use a K-wire to fix it transversely. So always... so you fix it with that so that it is maintained...
Then sir, K-wire will impinge the articular fragments.
No, you don't have to go like this. Always transverse. Always transverse. Never put in oblique K-wires because they are likely to migrate.
I think you can always fix those fragments if they are reasonable size by a transverse screw. And K-wire is not a good enough option because it doesn't provide stability. Other option is that you wedge that fragment between the two major condyles.
That is what we do.
And that stabilizes
that is exactly what...
very well mobilize it.
That is exactly what... K-wire alone is insufficient for intercondylar fixation. K-wires alone are there. So K-wire is an added thing over and above the screw fixation. But never compress too hard so that the trochlear width is compromised. That's the take-home message. So I think we'll end this, and I think I'm thankful to all the colleagues for finishing on time. And I just announced that the next session will be a conference lecture, and that is from 10 o'clock. So we have a few minutes more for you to go out and have tea or coffee. Thank you very much.
Dr. Sandhu from Amritsar, to please chair the session. उसके बाद ये लेक्चर दुराई स्वामी वाला चेंज हो गया है, कल हो गया, डॉक्टर ब्लिक्स लेंगे, इट इज एन एपोनिमस लेक्चर ओनली, टेकन बाय डॉक्टर ब्लिक्स। तो ये सेशन हमारा खत्म हो जाएगा सर। सेशन विल बी एंडिंग एट 11:45। यहाँ पर हमारा फ्री टाइम है, तो हम इस सेशन को प्रीपोन करेंगे हैंड वाले, वो मैं कर दूँगा सर, वो कर लीजिए। हाँ सर।
Friends, let us start with the next session, and the stalwarts of our association would be speaking during this session. And on your behalf, I request Dr. Pruthi to please give his talk on current concepts in the management of trochanteric fractures. Dr. Pruthi, please. Dr. Pruthi is a very senior member of our association. He has been head of the Department of Orthopedics in Medical College, Agra, and he has trained many orthopedic surgeons who are now heading the departments in different parts of the country. He has presented many papers in the conferences and has organized many national conferences also, and is playing active part in today's conference also.
Respected Dr. Sandhu Saab, Dr. Sadiq ji, my mentor Professor K.P. Srivastava. I'm thankful to IOA for giving me this opportunity to talk on this subject as a conference lecture. I'll be speaking on the current concepts of the management of trochanteric fractures. Friends, this fracture is a problem for all of us simply because the impact of this injury is nasty. The latest reports say that 17% die within 6 months, 25% have reduction in their life expectancy, and 50% have a deficit in their activity of daily living. We must do better. This is a challenge for us. We must do better. The predictors for the hip fractures outcome are pre-injury physical and cognitive status, the ability to visit friends and go for shopping, presence of home companions, post-operative ambulations, and post-operative complications. And out of these predictors, surgeon has a control on the last two, and that is the post-operative ambulations and the post-operative complications. The pre-operative management needs a little change now. One has to tune up the correctable comorbidities. These patients have to be operated early. That means the surgery is urgent, but is not an emergency surgery. Maintain the extremity in position of comfort. The various RCTs have clearly mentioned that the preoperative buccal traction is of no value now. General versus spinal anesthesia, this hardly matters. Both have the similar outcome. This has been well proven by the literature. First and the foremost thing that we require is a plain X-ray AP view, preferably in a neutral position or internal rotation, and a cross-table lateral view. What helps us to decide about the planning is a traction view. If possible, this traction view will give you more informations regarding the management. The factors which influence the construct of the strength, you all are aware of these factors. The uncontrolled factors include the fracture geometry and the bone quality, and the fractures and the factors that can be controlled are the quality of reduction, the implant placement, and the selection of the implants. Friends, the stability is the ability of the reduced fractures to support the physiological loading. And when implant is added to it, implant supports the bone and the bone supports the implant. Both are essential. In the fracture stability relates not only to the number of the fragments the trochanteric fracture has, but it also relates to the plane of the fracture. If you see, the importance is of posterior-medial part. If it is intact, it makes the stability after reduction, and when it's broken, it converts a fracture into an unstable one. The plane of fracture, when it is too fragmentary, it makes your job simpler. But when the lesser trochanter gets involved, then it becomes an unstable fracture. The number of fragments increases. The number of fragments they increase, the instability increases. And lastly, even with there is no number of increase in the number of the segments, but this line converts this into an unstable fracture. Though it is too fragmentary, you call it a reverse oblique fracture. This is a very common classification being used by most of us in the stable and the unstable varieties. Now, what's important about this is, in the stable regions, stable fractures, the location of the lesser trochanter, whether this lesser trochanter is with the proximal segment or is with the distal segment. That is a clue for creating problems in reduction and overcoming those problems of the reduction. The rest you all know. Here the posterior-medial has gone, and this is one which is grossly unstable. So we have a stability and instability as far as this classification goes. The importance is of the posterior-medial segment. These are the varieties of the unstable fractures. Posterior-medial segment is involved. There is a reverse obliquity, and there is a subtrochanteric extensions, and the new one which has been added to it is the transtrochanteric fractures. Now, coming to the bone quality, a younger person has a dense cancellous bone throughout the proximal femur, but in an elderly person there is not the marked loss of the trabeculae. So what's important is we must place our implants where the remaining trabeculae resides. That is very important. Now, in these poor quality of bone, should we strengthen the bone implant interface? The literature has a difference of opinions, and the polymethyl methacrate, it has 12 to 37% increase in the load to failure. CPCC has 15% increased yield strength. The clinical factors in 2010 influence the delivery, the cost, and the complications must be considered. Hydroxyapatite